Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell. I'm your host, and joining me today are Kate Leslie and Mike Grocott.
Hi, Desiree.
Morning.
Good morning. Thanks for joining me this morning.
Always a pleasure.
It's an early start for day 2, but we are raring to go, and we're really excited about our guest, Kate. Please, why don't you do the introductions?
So we're very lucky to have Dr. Harriet Hopf, who is from the University of Utah. And Harriet is one of my oldest friends in America. I met her way back when we were both fellows at UCSF. So welcome, Harriet.
Thank you, Kate. I am so excited to be here.
So can you tell us a bit about yourself?
Sure. I am an anesthesiologist, obviously. I also have an appointment in biomedical engineering at the University of Utah. I did my anesthesia training at UCSF and was on the faculty there for 14 years, which is obviously where I met you. And then I moved to Utah about 19 years ago. And my focus, I've had sort of 2 big foci in my career. The first was, how do we reduce surgical site infections? And particularly, how do we convince anesthesiologists that they have a role to play in reducing surgical site infections? And then the other side of it is really, how do we make faculty successful? How do we design policy so faculty are successful? And also, how do we help faculty understand what they can do to be leaders, to get work done?
So terrific. So before we get on to sort of developing people, let's talk about surgical site infection, which is a favorite topic here at Top Med Talk.
It is, actually. I feel partly responsible for that.
Well, you are. So you did some pivotal animal research about oxygen and surgical site infection. Do you want to tell us a bit about that?
I will say most of the animals I studied were human volunteers and patients.
Right.
So I worked with a surgeon, I think Tom Hunt, who was the first guy who in the early 60s said, oxygen seems to be important for wound healing. And he was kind of poo-pooed, and people said, oh, neutrophils don't need that much oxygen. And we went on to show that they in fact needed oxygen at a level of about 40 to 80 to function at sort of their average normal rate, 40 to 80 millimeters of mercury, should give my right. And then when I joined the lab in 1987, we were kind of doing parallel lines of, okay, in animal studies, what is the level of oxygen neutrophils need to kill bacteria, and what is the level in wounds? And we had moved on to measuring human volunteers, where the level is about 65 millimeters of mercury, which falls nicely into that neutrophils work range. But when we measured oxygen in wounds in patients who had surgery, the range, there were some who were normal, like 10% were at that sort of 65-ish millimeters of mercury, but a whole lot were down at 10 or 20 millimeters of mercury. And really the vast majority. And then we did a study in 130 patients who had surgery. We measured them on post-op day 0, 1, and 2 and showed that their risk of infection was inversely related to the wound oxygen level.
And you were measuring that with micro catheters in the wound?
It's actually a really clever little system. It's a 20-gauge catheter, and you swedge on a piece of silicone tubing with a spinal needle, and then you just push, you make 2 little holes and you pull it under the system so it's just under the dermis, so it's in that subcutaneous fat layer. Silicone is permeable to oxygen, so you fill that catheter, or you fill the tubing with saline, and then you can put a probe into the tubing, and you can flush it so you get sort of a fresh saline, and it takes about 15 minutes for it to equilibrate with the tissue around it. You get a measuring of about 400 micron core of tissue, what the wound oxygen is. And then you can measure it constantly for 2 to 3 days. After 2 to 3 days, it gets neutrophil, and they start to consume oxygen. It becomes less accurate. But it gives you a really nice way that you could continually measure once a day, much easier than leaving something in. And you can have really any oxygen electrode. We started with a Clark electrode, and then we moved on to an optical electrode, an Optode, which was great. And then the company went out of business, and then we went back to another Clark electrode. You can calibrate it in air and put it in, and gives you great numbers.
And what did you find out?
So in normal volunteers, I said it was 65. If you give them, a face mask, 100% oxygen, or not obviously 100%, but high flow oxygen to breathe, it'll about double to about 130. But in patients after surgery, a very large number of them, 80, 90% of them, it was low, 20, 30 millimeters of mercury. And when you give them oxygen, it didn't really change. And so when you sort of think about why is that, if you think about blood flow to the skin, there's two things that are really controlling blood flow to the skin. Most of your organs match blood flow and oxygen delivery. So like in your heart, in your brain, however much you need, that's how much you get. The skin has two roles. One is temperature regulation. The skin uses about 1% of your body's oxygen consumption. So it doesn't use very much oxygen, but it gets about 20% of the blood flow, which seems ridiculous until you realize that's how you get rid of heat. And also that's where you can vasoconstrict to maintain your core temperature. And also when you are bleeding or hypovolemic, it's a volume reservoir you can shunt to the core so you don't lose urine output, you don't lose blood pressure till you lose 20% of your blood volume. So that's all great until you get a wound, which would like to have that oxygen supply, but the wound can't locally manage. It's all managed centrally, central nervous system or sympathetic nervous system. And so in those, now I look back at patients in the 80s, they're hypothermic, right? We're not great at volume replacement. They're in pain. We don't have great pain relieving. And then it's stress as the other thing. And so that's probably why they're all hypovolemic. We did a bunch of really interesting studies like giving patients epinephrine infusions, giving volunteers, epinephrine infusions to see what that would, low dose epinephrine infusions, and showed that, when you get to a level approximately equivalent to what you might measure in the PACU, their subcutaneous oxygen goes down. We took volunteers, we made them shiver, we made them sweat, and showed that when you make them cold, their oxygen level goes down by about 50%. We had smokers smoke 2 cigarettes and their subcutaneous oxygen went down about 40%. So we could identify all these ways to reduce wound oxygen. And then the next step, and this is where we collaborated with Dan Sessler, which is really how I got to know you, with this idea of, can we interrupt the sympathetic nervous system? Can we keep people warm? Can we give them the right amount of volume? I love the idea of investigating stress. We never really did a whole lot with that. And so we got hypothermia, volume, pain. We did a little bit with pain. But I will say the first big study was the normothermia study that Andrea Kurtz led. We didn't have enough patients at UCSF, so that was done in Austria, but it was sort of designed at UCSF. And I think once you warm people up, I think we've actually solved a lot of our old problems, because even if you're not perfect in every way, if they're warm, hypothermia is such a overwhelming signal. So I think that sort of transformed things. So
Okay, can I pause for just a second and ask a question?
Yes.
And part of my role is I'm Vice President of Clinical Quality for North Star Anesthesia. We have over 200 facilities across the U.S., and I hear from SSI, or Surgical Site Infection Committees, on a very regular basis about maintaining normothermia, all the things.
Yes.
There's the SSI bundles, as they call them.
Right.
Right. And so I get a lot of calls about temperature management and how do we do that? And are we falling out, as they say, of their range? Since you have been huge in this space and been formative in these studies, I would love some clarification. I've talked to Dan a little bit about it.
Okay.
But when it comes, because I'm going to cut this out, I'm going to use this
Okay.
going forward, is what are the thresholds that we're looking at?
Oh.
And, right, I know. And is it intra-op temperature, or is it the perioperative temperature management?
So I would say, the original study was core temperature of 34.6 versus 36.6. And 34.6 is clearly bad.
Exactly.
It also was clearly what was normal when I was training. And
Oh,
I was told,
really?
that's just normal. That's just what happens with anesthesia.
So at that time, there were no effective warmers. And then Scott Augustine invented the bear hug, and Dan Sessler did the research about that. And that completely transformed temperature management. And it came along at the same time as research by Harriet and others about the dangers of hypothermia and what you could do to improve it.
But I did not realize that's what temperatures were then at that time.
And in fact, I was working with a surgeon, and we were going to do a study where we were letting his patients get cold. And I said, your patients will be 35 and, we're going to warm them in the PACU and see. And he said, I don't want my patients cold. And I had to go show him anesthesia records. He did not believe his patients were cold. He had by that time learned he didn't want his patients cold, but he didn't know that they were cold.
Oh, yeah.
So, we didn't have a way to keep them warm.
So the WHO, in their guidelines for this or guidance for it, it's 36.
Right.
Their temperature threshold. Now, the work that I've seen Dan Sessler is 35, 5, 30. And in CMS, So they designate 35.5 as the temperature threshold for perioperative temperature.
So I would say 36, a little bit arbitrarily chosen, right? Like we don't really know. We've got 2 degrees. What I would say is it's nice to aim for 36. I think at 35.5, patients feel a little bit cold. And so if you're at 36, I will also say, I think intraoperative temperature is, to my mind, more important because anesthesia inhibits thermoregulation. You emerge, and especially now, our patients are pretty awake when they get to the PACU. And when you emerge, now you don't have the anesthesia as much, and so you have thermoregulation. And if you're 35.5, you vasoconstrict pretty hard. And there's been a big change. So one of the things I think about is all of our patients in the PACU when I was a resident, their pulse oximeter stopped working because they'd get cold in the OR, and then they would just clamp down. And we used to do lidocaine finger blocks, so their pulse oximeter would work. That was our little... Now that's our residents laugh at me when I say that. They don't have that problem anymore because, so I think 35.5 is fine in terms of outcomes. I think for a patient comfort, I like to be warmer than that.
Up a little bit.
And I will say we have been doing pre-warming with forced air since 2009 at Utah because I got there and I was like, we need to pre-warm. It seems important. We're not perfect 100% on getting it done. That prevents that big initial drop from redistribution. So I'm a big believer in pre-warming. We warm everybody. My mom had about 10 knee surgeries when I was growing up. And when I went to med school, and my parents were PhDs, they were not enthusiastic about my going to med school. So my mom said to me, while you're there, if you're going to waste your brain like that, could you at least find out why it's so important to be shivering in the recovery room after knee surgery? And somehow my life led me to go, it's actually not only not important, it's not important to be cold, and it's bad for you. And so I think the patient comfort sometimes has gotten, like Dan Sessler did some great data collection on how uncomfortable patients are in the PACU, and they are, shivering is one of the
worst.
Well, nausea and itching are bad. So I want people not to be shivering, and I kind of think Dan may have chosen 36. I think it was pretty arbitrary because you don't shiver.
Yes. So he recently published a trial with colleagues from China, and it was a large trial in major non-cardiac surgery. And the bottom line of that one was that 35.5 was the point at which there were not so many bad side effects afterwards. But Harriet's completely right about shivering. The shivering threshold will go up as the anesthetic concentration goes down at the end of surgery. And if it's not above 36 or possibly even 36.2 or 3, the patients will shiver.
Yes.
Unless you warm their skin
Actively.
where you trick the brain into thinking that everything's okay.
Which we do. Sorry, I'm going for a deep dive on that one.
Because I think it's really useful. It's kind of seen as mundane, but just to remind ourselves how important the temperature management is.
I think it's really important to talk about why, because I think people are like, oh yeah, we got to keep our patients warm. But if you aren't aware of mechanism, then you don't necessarily do it well.
Just into the oxygen bit of it.
Yes.
Which is how we got into this.
I know.
Got
That's what he wanted to
an
talk about.
interest in oxygen generator. Where did you conclude with that story?
I don't know that it's, but so what I would say is there are 4 ways that oxygen is crucially important in wound healing, and it's all at levels in that sort of 40 to 80 range. So I talked already about neutrophils. The major neutrophil killing of bacteria, one major mechanism is the oxidative killing, has a Km of around 80 millimeters of mercury, 40 to 80 millimeters of mercury, which means it's going at half its maximal rate. So if you raise it up, you actually make it go faster. So that's a useful thing. It turns out that hypoxemic neutrophils release all the oxidative stuff, and normoxic neutrophils don't. You don't want them to get hypoxic. You want them to be
Free radicals.
free radicals and things that cause harm. The second thing is collagen deposition, proline and lysine. That's the triple helix, right? It comes out as procollagen. Then you make a triple helix by hydroxylating proline and lysine residues. I don't talk about this as much anymore. And
You're like pulling all this out.
proline and lysine residues. And that is oxygen requiring as well. That's at about 25 millimeters of mercury Km. So it's not as oxygen dependent. In that normothermia study, we did show better collagen deposition. The third thing is neovascularization. And that is also dependent on oxygen. Probably it's a secondary effect, mostly from you need collagen for the new vessels to lay themselves down. But there is also data on endothelial cells migrating and making vessels faster with oxygen. And then the final step is epithelialization, and that was shown many years ago in the 60s to be dependent on oxygen. George Winter in 62 invented basically Tegaderm and showed that wounds covered with that compared to dry wounds healed faster. And part of that was because it's oxygen permeable.
But is it the administered oxygen that's the key variable? Because I think what you told us was that actually the temperature control is important, and maybe the fluid status and the pressure status. Is the administered oxygen important or not? It's
a two-step process, I would say. Because remember I said you give oxygen, if they're well perfused, it doubles. If they're not well perfused, it doesn't change. And so what I would say is giving oxygen to someone who's vasoconstricted is not helpful. You make neutrophils work better in someone who is well perfused by giving them more oxygen. Do you need more oxygen? Not always.
And might you cause harm?
I don't think so. I would say when I look at all the data, people have worked really hard to show harm, and there have been a couple of secondary analyses that suggested harm, but when I look at the big analyses, I have not seen a lot of harm. So I will say, I think 80% was a good choice to begin with because you don't get absorption atelectasis. I would also say we have a special thing, very exciting, that's never been used before called PEEP. And if you give a patient PEEP, they don't get atelectasis. And so,
I would it here first on Top Med Talk.
I'm a little worried about absorption atelectasis. It averages about 10% atelectasis, which feels like it doesn't really, we actually did a study where we looked at, does it affect postoperative oxygenation, and it didn't. So what I would say is, I don't think absorption atelectasis makes me nervous. I know that people worry about free radicals. I will say you cannot have wound healing without free radicals. Also, that is why if you're in an ICU getting high FiO2, you get fibrosis because now you've initiated wound healing, right? So high oxygen is bad for you for more than a few days. Fortunately, most of our surgeons can get their procedures done in a couple hours. I also am a hyperbaric medicine physician. We give people 200 to 280% oxygen. It's the equivalent of 2 to 2.8 atmospheres of oxygen for a couple of hours. There are not harmful side effects of that.
But they do vasoconstrict, and some of them coronary constrict, don't they?
So if you have, yes, but they don't reduce oxygen delivery because you have so much dissolved oxygen that they...
Not in hyperbaric, but in high normobaric, there is some data suggesting oxygen delivery goes down.
Depends on the tissue you're looking at.
And this is amazing conversation. You're coming back when we have more time, because this has been super fun. I love this conversation. There have been the PEEP thing, mind blowing. So we will definitely have. I want to talk about leadership. I want to talk all about that work, but we have run out of time.
It's been so much fun. Thank you for
so much fun
letting me talk about the stuff that drove my whole life. But can I just add one more thing, which is, all of this oxygen stuff is great, but if you do not do hand hygiene and scrub the hut, there is no point.
Thank you.
Brilliant.
Awesome. Well, I can't tell you how much fun we've had this morning. This is great. Please do come back and chat with us anytime.
I would love to.
And Kate, thanks for the recommendation. Good one. It's a winner. All right. Yeah. And thank you so much for listening to Top Med Talk. You can always find us at topmedtalk.com. We're on your favorite social media platform, your favorite podcatcher. If you find us there, thumbs up, 5-star, give us some comments, all that good stuff. Thanks everybody for listening. Have a great day. Cheers.
Cheers.
Top Med Talk.
Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org. That's ebpom.org.